Hello, friends. So, thanks for the Hicks team for having me for this conference. So, I'll be talking on this very important basic science topic: fluids, glycocalyx, and capillary leakage. So, this is a little dry topic. So, I've tried to put in a lot of pictures to make understanding a bit easier. But it's a very important concept for all the trainees and for all the colleagues to understand. So the topics that I would be covering is the structure of EGL, which is endothelial glycocalyx layer, functional importance of glycocalyx, EGL and fluid therapy, endothelial glycocalyx layer and clinical pathophysiology, and how this has an impact on different disease conditions like heart failure, nephrotic syndrome, liver cirrhosis, sepsis, pulmonary vasculature, and what are the modalities that we have available for protection of EGL. So these are some of the topics that I would be covering. So let's dwell into what is the structure of endothelial glycocalyx layer. So it's a little new concept which has evolved over last decade. So the structure of EGL, it contains various components. So basically, for all the listeners, understand EGL as a slime that is present on the endothelium of the blood vessels. So EGL has proteoglycans, glycoproteins, and glycosaminoglycans. So these are some of the important constituents of this slime that is present on the endothelium of the blood vessels. And it also has ACE and antithrombin 3 and superoxide dismutase 3, and it contains chemokines and growth factors. So basically, these are some of the enzymes that it constitutes, along with these structural units, which are proteoglycans, glycoproteins, and glycosaminoglycans. So the proteoglycans forms the central core, or this is the important structure which gives stability to the whole of endothelial glycocalyx layer. I'll show a lot of pictures. And this proteoglycans, which forms the core on, or the basic fundamental foundation of this EGL, is attached to other proteins which are syndecan and glycican. And this proteoglycans is connected to glycosaminoglycans. And there are other structural units that proteoglycans is connected to along with syndecan. So this one, what you see is the syndecan, this is the glycogen. So it is also connected to other structural units like mimican, perlecan, and biglycan. So for all the listeners, please remember there are two important aspects: proteoglycans, which forms the central core, and glycosamine glycans are another important structural units. So some of the constituents of glycosamine glycans are heparin sulfate, hyaluronic acid, and chondroitin sulfate, dermatan sulfate, and keratin sulfate. So these are some of the structural units that constitute glycosaminoglycans. And these glycosaminoglycans, all the names that you see are negatively charged. And the main function of these glycosaminoglycans is it is negatively charged, and it tends to repel or tends to drive away these blood product constituents, which is red blood cells, white blood cells, and platelets. So the whole utility of glycosamine glycans, which forms the structural unit of endothelial glycocalyx layer, which is present on the endothelium, is to make sure that none of these cellular constituents like RBCs, WBCs, and platelets stick to the endothelium. So it's a very important functional aspect of glycosamine glycans. They are negatively charged, so they sort of repel these cellular constituents. So, and when you look more closely, the structure of EGL, it has a fixed component which is sort of fixed to the endothelial layer, and then there is a dynamic part which is not fixed and which is volatile. So the fixed part contains all the syndecan, glycoprotein, glycosaminoglycans. The dynamic part consists of other enzymes like ACE, antithrombin 3, SOD3, albumin, and it also contains adhesion molecules like platelet endothelial cell adhesion molecule, intracellular adhesion molecule, and vascular cell adhesion molecule. So as I said, so this is the endothelial cells, and the fixed components are all these glycosaminoglycans and proteoglycans. And the dynamic part is all these plasma proteins, and the hyaluronan, as you see, or hyaluronic acid, this is free floating sort of an domain, and this is not attached to any core protein. So these are some of the other structures that you would find. So basically showing different pictures as to how this endothelial glycocalyx looks. And when you look into the electron microscope, So this is a vascular lumen. So basically you see glycocalyx as a sort of a slime sitting on the endothelium. So this is the electron microscopic view of the glycocalyx. So let's jump into the functional importance of glycocalyx. So as I said, the intact glycocalyx is negatively charged and it tends to form these branches which cover up and protect these adhesion receptors. And these adhesion receptors are of two types. One is the selectins, which tends to bind to histamine and thrombin on interleukin 1 and tumor necrosis factor, which are positively charged. And the second type of adhesion receptors are the immunoglobulins, which tend to constitute the adhesion molecules, vascular cell or platelet endothelial cell adhesion molecules. So what is the importance of or the relevance of glycocalyx? So whenever this glycocalyx forms an important protective layer to the endothelium, and the damage to the glycocalyx typically happen in any of the systemic insults like systemic inflammatory response syndrome or polytrauma, sepsis, where there is a multi-system involvement. This glycocalyx layer gets breached, and that is where the whole internal milieu gets affected, and there is a transudation of fluid from the vascular compartment to the interstitial. So that is the whole relevance of EGL. And rapid infusion of fluids, rapid administration, if you rush a lot of fluids, that also can cause damage to the endothelial glycocalyx, EGL. And diabetics also, EGL can get affected. So let us look into the functional aspects. So the whole internal milieu of the vascular integrity is maintained by the Starling's principle. So what Starling principle says is there are two forces which tends to balance the fluid. So one is the hydrostatic pressure at the arteriolar end, which moves the fluid out of the arterioles. And then there is this oncotic pressure at the venule end, which tends to push the fluid inside the veins. So this is determined by this formula, which is this is the reflection coefficient, and it is the difference between the capillary oncotic pressure and the interstitial oncotic pressure. So the whole understanding now is the newer understanding is this interstitial oncotic pressure is having very minimal effect in driving the fluid into the venule. So that is the whole principle or the concept at this point of time of the EGL, where the EGL plays a role. So the interstitial oncotic pressure is determined as having least effect in driving the fluid into the venules. So that is the understanding. And with that understanding, we have tried to understand that the albumin, initially it was thought that it will enter into this endothelium by endocytosis. Now the understanding is this endothelial glycocalyx layer that you see here, the violet one, the albumin tends to get adsorbed on the surface of this EGL, and that produces a osmotic pressure. Okay, so that is called as oncotic endothelial glycocalyx layer oncotic pressure. So that is the pressure which determines the movement of the fluid into the venules. So 60% of the colloid oncotic pressure is found to be maintained by this albumin that is adsorbed on the EGL. So that is our current understanding. And the osmotic, and there is a small space just below the EGL called the subglycocalyx space. So the osmotic gradient that exists between the EGL and the subglycocalyx space is what is determined to be important in maintaining the vascular integrity and maintaining the movement of the fluid into the venules. So the revised Starling principle, the initial Starling principle, we said the movement of the fluid is mainly determined by the colloid oncotic pressure minus interstitial oncotic pressure. Now we are telling the revised Starling formula simply states that the movement of the fluid is determined by the colloid oncotic pressure minus the glycocalyx oncotic pressure, which is called as pi g. So this is the whole revise. For the trainees, simply to understand, before our Starling's principle, our understanding was it was the capillary oncotic pressure minus interstitial oncotic pressure. Now it's the capillary oncotic pressure minus the glycocalyx oncotic pressure is what determines the movement of fluid. So as again I mentioned, so the difference between, so the movement of the fluid from the lumen. So I've just put it pictorially. So the red one is the lumen. This is the dynamic part of the EGL. This is the static part of the EGL. This is the endothelial, and this is the interstitial space. So the movement of the fluid from the vascular lumen to the interstitial is not determined by the Starling's law, which is the capillary oncotic pressure minus interstitial. Rather, it is determined by the capillary hydrostatic pressure and by the glycocalyx oncotic pressure. So that is our whole difference in our understanding. And the difference in this fluid, capillary hydrostatic pressure and the glycocalyx oncotic pressure, is what determines the movement of the fluid from the lumen into the interstitial space. And as I've already mentioned, the capillary hydrostatic pressure plus interstitial is sort of de-emphasized. The interstitial oncotic pressure is found to be very low or insignificant to move the fluid from the interstitial space to the venular end of the capillary. So that is our whole concept of the EGL, that interstitial oncotic pressure is de-emphasized, and it is the glycocalyx oncotic pressure which tends to play an important role in moving the fluid to the venular end of the capillary. So that is our whole understanding. So when this movement of the fluid is not happening at the venular, then the lymphatics play an important role in driving the fluid from the venular end. So this has been our understanding. So as this picture again re-emphasizes, so it is the lymphatics which tends to drive the fluid from the venular end as well when this interstitial oncotic pressure fails to drive the fluid. So let's look at how this becomes relevant to the fluid therapy. So when we talk about the fluid therapy, you have isotonic fluid, hypotonic fluid, and hypertonic fluid that one would infuse. So it has been increasingly recognized that use of 0.9% saline leads to increased chloride administration, and that leads to hyperchloremic metabolic acidosis. And it has been found that hyperchloremia causes damage to the EGL layer, and rapid infusion of these isotonic fluids can cause shredding of the EGL, and this can lead to AKI, and it can lead to clotting abnormalities. And multiple trials like SMART and SALT trial have shown that balanced solution may be the way to go, which causes less acute kidney injury. But even it has shown there that chlorides, increased chloride administrations less than 110 millimoles can lead to metabolic alkalosis. So colloids have found to have some advantage in remaining in the intravascular space, and the low albumin. So I just put pictorially. So this is the vascular lumen. This is the EGL layer which lies above the endothelium, and this is the interstitium. So low albumin leads to leads to damage of the EGL layer, and this leads to movement of the fluid from the vascular lumen to the interstitial space. And the albumin has a lower molecular weight of 67 kDa. And it has been shown that in heart failure, the stretching of the atrium leads to the production of atrial natriuretic peptide, and that can also cause damage to the endothelial glycocalyx layer. And this movement of the fluid from the vascular lumen to the interstitial space can lead to a lot of inflammation and increased risk of infection and the clotting abnormalities. And when the EGL is damaged, it takes about 6 to 8 hours to regenerate, and it takes about 5 to 7 days to normalize. So this is something which most of you would know, that colloids tend to remain in the vascular lumen. And if you give the isotonic solutions, around 180 ml moves to the intravascular compartment. And if you give 5% dextrose, you would see nothing would move into the intravascular compartment. And as I said, in the heart failure, stretching of the atria leads to production of ANP, atrial natriuretic, which causes damage to the EGL. And this damage to the EGL can also lead to the activation of the systemic sympathetic nervous system. And this leads to driving of the fluid from the peripheral circulation and the splanchnic circulation. And there are other changes that this leads to. So in heart failure, it is shown because of these changes, there is increase in the capillary hydrostatic pressure, and there is a reduction in the capillary oncotic pressure. So this reduction in the capillary oncotic pressure drives the fluid from the vascular lumen to the interstitial space. And in interstitial space, there is increase in the interstitial hydrostatic pressure. So when we give diuretics in the heart failure, it leads to reduction in the capillary hydrostatic pressure, and it reduces the movement or the extravasation of fluid from the vascular lumen, which we call it JV. And because there is reduction of the fluid transudation or extravasation from the vascular lumen, most of the drainage happens from the lymphatics. So that is the benefit that one would confer by when diuretics are administered. So the whole way to address this problem is obviously sodium restriction, beta blockers, AC inhibitors, ARBs, and aldosterone antagonists. So how is it the relevance of EGL in nephrotic? So in nephrotic, in kidneys, see, endothelial glycocalyx layer is present in every blood vessel, And in nephrotic syndrome, in the kidney, the EGL is very scant and it can get easily damaged. And albumin is not meant to be present in the tubules. So when there is damage to the EGL, you will see albumin present in the tubules. And that is the first thing that we would see in the nephrotic syndrome, leakage of the protein. And in nephrotic syndrome, it is shown there is degradation of this EGL. And now there is more research in trying to ascertain this degradation product in the blood, like identifying the syndican or glypican in the blood. And so the main causes for edema in the nephrotic is the hypoalbuminemia, neurohumoral factors, and low plasma volume. And there is activation of this sodium channel receptors. And there are two hypotheses as to why there is edema. There is underfill therapy, where underfill therapy postulates that there is reduction in the capillary oncotic pressure, and this reduction in the capillary oncotic pressure leads to increased transudation of fluid across the vascular lumen, increased JV. When there is increased transudation of fluid or extravasation of fluid from the vessels, then there is relative hypovolemia in the blood vessels. That leads to activation of renin, angiotensin, aldosterone. That leads to sodium retention. So when we give ACE inhibitors in nephrotic or ARBs, it preserves this capillary oncotic pressure and reduces the proteinuria. So what happens in liver cirrhosis? So liver cirrhosis, there is activation of Kaplan receptors, which leads to a lot of inflammation, fibrosis, and neoangiogenesis. And this fibrosis in the liver architecture leads to reduction in the synthetic function, reduction in the albumin, and there is a slowing of the blood flow. And this slowing of the blood flow in the portal veins leads to increase in the pressure in the portal veins, and that leads to increase in the portal vein pressure. And because there is increase in the portal vein pressure, there is increase in the transudation or extravasation of the fluid, leading to the edema. And low albumin production by the liver leads to reduction in the oncotic pressure, and that leads to increase in the JV, which means increase in the extravasation of the fluid, leading to edema. And the treatment in liver cirrhosis, as you would see, would be on the principle of increasing the oncotic pressure, reducing the portal vein pressure, paracentesis, and administration of diuretics and beta blockers. So let us quickly look into what is the role of EGL in sepsis and EGL. So in sepsis, as you see, the gaps between these endothelial cells significantly increase, and increase in the gaps lead to increase in the expression of these adhesion molecules, which is platelet endothelial cell adhesion molecule or intracellular adhesion molecule. And these increased expression of this adhesion molecule leads to migration of these leukocytes and stickiness of these leukocytes to the endothelial cells. And this leads to, because there is increased gaps in the endothelial cells, there is escape of fluid from the vascular lumen to the interstitial space. And the presence of inflammatory mediators leads to loss of vascular tone, pooling of the blood, and leads to procoagulant state. And there is increased escape of this fluid from these gaps in the endothelial space. So when you see, when the glycocalyx is intact, as I said, the glycosaminoglycans are negatively charged, so they repel the leukocytes. So the leukocytes do not get attached to this EGL. But when the glycocalyx is degraded and there are gaps that are formed in the endothelial cells, you will see these leukocytes getting into the gaps and sticking to the endothelial cells. When the EGL regeneration happens, these liposomes act as a nanocarrier, which brings in the pre-assembled glycocalyx and attaches it to the endothelial cells. And what is the relevance of EGL in pulmonary vasculature? Again, in pulmonary vasculature, EGL appears to be much thicker, but when there is breach in the EGL, there is extravasation of these inflammatory exudates into the alveolar lumen. So this is the alveoli and this is the pulmonary vessels. And there is transudation or movement of fluid into the vascular lumen, and there is increase in the nitric oxide signaling in the alveoli. All this leads to ALI and ERDS. Now, again, the research is towards direction of identifying and detection of these EGL products in the blood to determine whether patient is at a risk of developing ALI and ERDS. So there are different ways to protect endothelial glycocalyx layer. So this is one of the newer molecule which is which is proposed to protect this endothelial glycocalyx layer in the respiratory endothelium, and this was used in COVID patients also. Aviptadil, which is vasoactive intestinal peptide, and this is predominantly present in the alveolar type 2 cells, and it acts on the VPAC receptors present in the alveolar type 2 cells and on the ACE receptors. And 70% of the VPAC receptors are present in the alveolar type 2 cells. And this Aviptadil, by acting on these VPAP receptors, helps in improving the gas exchange, helps in improving the gas exchange, surfactant production, and it tends to protect the alveolar type 1 cells, and it prevents the NMDA activation of caspase and protects the extravasation of the fluid and inhibits the interleukin 6 and tumor necrosis factor alpha. So just last, I'll take 1 or 2 minutes extra. Protection of EGL is predominantly by maintaining the good milieu internally, good glycemic control, use of steroids, and they've used etanercept, which inhibits tumor necrosis factor alpha. Antithrombin 3 blocks the transcription factor and nuclear factor kappa beta, and it regulates immune response, both innate and adaptive immune response. And etanercept, along with the antithrombin 3, has shown to block IL-6, tumor necrosis factor, and transcription factor. Statins, we all know, is protective. It prevents free radical activation and free radical damage to the endothelial cells, reduces the CRP. And sevoflurane is found to protect the EGL by preconditioning and post-conditioning, and it attenuates lipocataps B. And they've used nephrin, which is bis-benzyl isoquinoline, which prevents the production of reactive oxygen species, ROS, by the mitochondria. So suloduride is another one, glycosaminal glycans, which contains 80% of low molecular weight heparin and 20% dermatan sulfate. It is shown to be very helpful in regeneration of this EGL. And the new research is towards identifying or identification of these EGL products in the blood, in particular syndecan and glypicans, as you see these two structures. Identifying these in the blood early on tends to identify the patients who are at a risk of vascular integrity abnormality or the loss of vascular integrity, which leads to extravasation of the fluids and the after effects of organ damage that occurs. So that's in brief about the whole endothelial glycocalyx layer. So hope I made it little simple for you. So it is a new concept. So just remember it as a slime that is present on the endothelium, and it prevents the movement of fluid, abnormal movement of fluid from the vascular lumen to the interstitial space. And we have tried to understand how this EGL gets affected in different disease systems and how our pharmacological interventions helps in mitigating this breach in this EGL layer. So thank you very much. So end with this beautiful quote: you never know how strong you are until being strong is the only choice you have. Thank you, one and all.